I'm Nathan Sussman. I'm professor of economics and the director for the Center of Finance and Development. And this event is organized by the International Global Health Platform and the Center for Finance and Development. As you can see, this is the Global Health Platform is celebrating 10 years of activity, convening great discussions on global health issues through the lens of governance, politics, and power. And today, we're going to talk about the panel. The distinguished panel is going to discuss and offer views on what seems to be an impending funding crisis for global health. This is a funding crisis, by the way, which is shared not just in the health issues, global health issues, but is more general in terms of sustainable finance, blended finance, impact investing. After years of growth, we've reached post-pandemic, around 2020, a plateau in financing for all these great issues that actually would have helped us fulfill the SDG goals by 2030. And this kind of stagnation brings to light the question, are we going to be able to actually achieve those goals in 2030 or not? And so any funding crisis, an economist would say that any funding crisis or challenge is an opportunity to actually rethink priorities and structures. And the distinguished panel today will offer views and insights of how we move forward given this challenge. Let me just stop this because this is really important. Some housekeeping rules. So the event is recorded, and the recording will be available on the Global Health Platform in 1 to 2 days. The platform is ghplatform.org. You can Google the center and find it there as well. During the event, because we're online, there are going to be 2 Q&A sessions, and those online are welcome to put their questions in the chat box on the platform. And if you can actually say who to which one of the speakers you're addressing the question, this could be helpful. Of course, live, it's easier to do. So without further ado, let me introduce our moderator, Stéphane Poussard, journalist at Le Temps. Stéphane, the floor is yours. And enjoy the event.
Hello, everyone. It's great to see that many people here in person, but also online. And I think we're about to tackle a very important topic that is very much in the press, not so much, but actually we are talking a lot about that. And as we saw, governments now are under fiscal pressure. They cut budgets in the development aid and things like that. We saw that with, for example, big government funders of global health, like Germany, like the UK, like France. It goes up to 30 to 50% cuts in the development aid, and this has obviously an impact. And so, with the panelists who are here, we're going to tackle this and see how we can maybe innovate, what impact it has in the field with people dealing with global health in the field. And obviously, as Nathan was saying, we still have a long way to go as far as the Sustainable Development Goals are concerned, and SDG 3, which is still underfunded. It allowed so far some progress, obviously, but we still think, and WHO thinks, that we still need to invest something like $200 to $380 billion a year by 2030 to reach the goal, or to approach the target that has been fixed. So without further ado, I'm going to hand the floor to David Evans. He's a visiting professor here at the Graduate Institute. He's one of the major specialist of global health financing. So we are very happy to have him here. He's going to set the scene for the debate and the 2 panels discussions we're going to have very soon. So David, please, the floor is yours.
Bonjour tout le monde. Hi to everyone. Thanks very much, Stefan. It's a pleasure to be here. As Stefan says, my role is to set the scene a little bit for the subsequent discussions. I'm going to initially step back and ask what chance have the countries that are currently receiving development assistance of raising and spending money themselves on health, given the macroeconomic climate. And then I'll reflect a little bit on what we know about development assistance and development assistance for health for the next 5 years. I would like to raise these issues more for discussion in the subsequent panel discussions rather than to provide you with definitive answers. I also would like to acknowledge that a lot of the analysis that I'm going to present you was done in collaboration with Christoph Kurowski and Martin Schmidt. So as I say, I'm going to be looking at the prospects for countries to increase their own spending, what this means for their capacity to spend more on health, and then what role for development assistance for health. This looks complicated. It's not complicated. The vertical axis is government spending, general government spending. So it's on everything, not just health. Okay? I've divided countries into the 4 World Bank income groups: LICs, low-income countries, lower middle-income countries to the right, upper middle-income countries, and high-income countries. It shows the path of government expenditure pre-COVID, which we call the Great Lockdown, just to be a bit dramatic. And the dotted lines are the projections for the next 5 years to 2029. If you look at that graph, you'd think, okay, everything's good. All countries are going to be able to spend more on their development priorities. Unfortunately, you can't say that all low-income countries are the same anymore, if ever you could do it. Not all lower middle-income countries are the same. There's a lot of variation now in country prospects to move forward. And I've divided countries here into 3 groups. I'm only focusing on the low and the lower middle income countries for which we have data. So I've forgotten about the upper middle income countries and the high income countries that don't receive development assistance. These are the recipients of development assistance here. And I've divided them into expansion countries where you can see progress is going to be good for government spending over the next 5 years. The dotted line on the left-hand side, they're going to steadily increase if you believe the IMF, International Monetary Fund, projections of the future. The ones in the middle have a little bit more of a problem. Their government spending per capita, this is all adjusted for inflation as well, their government expenditure per capita is going to rise a little bit, but more or less stagnate. They're going to have a lot of trouble increasing government spending. And on the right-hand side, you've got a group of 13 countries, I can't read it properly, 13 countries that their prospects are very poor. Government spending is likely to fall over the next 5 years, remain below pre-COVID levels. Very substantial problem, okay? And you've got to add on to that something that I'll come back to later. Included in government spending is on-budget development assistance. So that's the development assistance that goes through government channels, either as part of the budget or parallel to the budget, but through the government fiscal system, it's already in there. So that's what the government, as the IMF is expecting, is going to happen in these contraction countries, even with the current levels or the projected levels of development assistance, their government spending is going to fall. So what does this mean for health. I've just done two scenarios. The IMF doesn't project this. I've got to now say, well, what do we think this means for health? There's two scenarios. The positive one there is what happens if health spending per capita continues at the rate pre-COVID. It's the very optimistic scenario. The second one is what happens if the share of government spending allocated to health stays at the levels that we observed in 2021, which is the last year for which WHO provides estimates of government health spending compared to overall government spending. Okay? So that's the share is constant, and not surprisingly, you will see the prospects for increasing government health spending are not good. In the contraction countries, they're sort of fairly stagnant. In the stagnation countries, similar patterns to what I described before. In the expansion countries, pretty good. Okay? So not all low-income countries are the same anymore. Some have good prospects of increasing their own spending on health. Some have very, very poor prospects, and some are in the middle. That's the major point that I want to take home from this. So, what do we know about development assistance for health? Again, those of you that work in this area will know that the data sources offer different pictures sometimes. I've taken this data from the OECD development assistance group, and these are disbursements reported by donors. Disbursements is how much went out, all right? You can see the pattern. In the early years on the left-hand side, this is all development assistance, not just health. In the early years of the century with the MDGs, there was a sort of big increase in development assistance. That kept going really until that orange bar where it looked like it was slowing down just before COVID. And then bang, COVID hits and development assistance overall goes up again. What about the share going to health on the right-hand side? Vertical axis is the proportion going to health, time on the horizontal axis, and you can see immediately before COVID, the share of disbursements going to health was declining. Bang, COVID hits, goes up. The big question for us now, and some of you probably know better than me what's happening in your domains, particularly NGOs, it went up, but then it started to fall in 2021, 2022. So that's disbursements. WHO keeps a record of how much development assistance for health goes to countries for them to spend. Disbursements reported by donors is not the same as how much goes to the countries for them to spend, because some of the disbursements, for example, is used to treat migrant or refugee health in the home country, for example. So not all goes to the countries for them to spend. I'll say a little bit more about that. But the same sort of patterns, that the amount that countries reported they spent on health from external funding stagnated before COVID, bang, went up. As I said earlier, in 2021 is the latest year for which WHO reports those numbers. The next set of numbers comes out in a couple of months, so we'll know about 2022, but even then it's a couple of years, not in real time. The other part about this is if we go back to the OECDs, what proportion of development assistance that donors report is called country programmable aid. So this is what the donors say the countries can program as opposed to the total disbursements. And you can see that the proportion of overall development assistance, this is not just health, this is for everything, the proportion of overall development assistance that the donors say countries can spend has been falling over time. That's global public goods, refugee health, influx of refugees to different countries, takes a lot of that. But the proportion going to the countries that need it has been going down. Now, if you look at the most recent figures of the OECD, it's a little bit difficult to interpret. The last year for which there are data is 2022. It shows disbursements actually increased a little bit for all development assistance. Commitments went down. If you're familiar with this, commitments are promises made by countries, and the promises are recorded in the year that the countries make the promise. But for some countries, the promises are made for 5 years. So it's not all designed to be spent this year. For some countries, it's 1 year, some for 2, some for 3. It depends upon the budget cycle of the particular country. Commitments have gone down, implying that over the next few years, you're likely to see the disbursements go down as well. So it's not a very promising situation for the contraction and the stagnation countries who can't spend more on health themselves. Okay, that's a brief setting the scene. As I said, I've got no definitive answers, but there are some problems. Some countries can't, it looks like, in the current economic conditions, spend more on health. The only way they can do that when their overall government spending is going down is to give more priority to health in government budgets. Very difficult to do historically when your government expenditure is falling. Giving more priority to health when the budget's falling is often very, very politically difficult. It doesn't happen very often. It happened in the financial crisis a little bit in some countries, but not all countries. Most countries, the proportion going to health fell, even in the 2008-2009 financial crisis. So the top right of that screen, there are real competing priorities at the country level. And as you will know, some of you are involved in this push to have more money for pandemic preparedness and response. Okay? It's very worthy. But if the budget's going down, where's that money going to come from? At the country level and domestically and internationally. And I'm sure it's something that we could raise in the discussion. There are some opportunities, as Nathan said earlier, that every problem has an opportunity as well. I haven't had a lot to chance to talk about the debt and the rising interest payments on public debt and what implication that has. But there's been a lot of talk about reducing the debt problems of some of these heavily indebted countries. There's talk about special drawing rights of the IMF and reform of the international institutions to try and give more money to these countries that are the most affected. So there is some hope along the way, improving the efficiency and equity of health spending, but the prospects for some countries are not good. And it is a question of whether now it's a time to think about changing the criteria under which countries get development assistance, no longer limiting it to just these big income group capacities. Many donors give to low-income countries, boom. Do we need to be more careful about which low-income countries now get it? Some can increase their spending themselves, some cannot. Okay, so I hope I've set the scene. I hope I didn't go too dramatically over my 10 minutes, but I hope we now have a very interesting discussion. Thanks to everyone.
Thank you very much indeed, David. I think you did set the scene. It's much clearer now, the challenges we face now in the future as far as financing global health. I'd like now to move to two different speakers. First of all, Erika Placella. She's head of health at the Swiss Agency for Development and Cooperation. And she's going to talk about the global health financing crunch from a government perspective. And I would like to invite also here Alenta Ghebreyesus. She's a health diplomat at the mission of Ethiopia to the UN here in Geneva. And she's going to give us also her perspective from a country like Ethiopia as far as the impact that a funding crunch might have on a country like this. So starting maybe with you, Erika, I would like to, because in Switzerland, we know that the Swiss government had to make budget cuts in the development assistance. Different agencies or different programs have been impacted. I would like to have your first take in 5 minutes about how the Swiss government approaches those problems and how does it address this financing crunch, since Switzerland has been very much engaged in global health and is also a very important donor country. You have the floor.
Do I have to open it or? It's open. Can you hear me? Okay, so first of all, thank you very much for the opportunity to be part of this conversation. It's good to have figures. We have statements, but most of the time we don't have figures, so it's good to have those figures, even if we are talking about projections and there are some structural constraints, some issues we don't know about. So, but it's good to have some projections. Well, again, to echo your introductory thoughts, Nathan, I believe that the tipping point for global health has already been reached. And it's a result and a consequence of the COVID-19 pandemic and the response of both. So we already, reached that paradigm shift. And from a donor perspective, the evidence of this paradigm shift is the competition for replenishment. You said it, I'm quoting you, competition in a zero-sum game. That's exactly what we have now. The proliferation of funds, the fragmentation of initiatives. Again, in this zero-sum game, the race to find the smallest comparative advantage and the sexiest narrative. That's also what we have. The call for a dedicated fund or budget pot or whatever to implement each and every resolution. So we also have that in every single negotiation fora. And of course, then the introduction of new global health instruments and so on, and related, again, budgetary pots to implement those instruments. So a very fragmented landscape. It's very difficult to navigate that landscape. And at the same time, as you mentioned, Stefan, budgetary constraints, call for greater rationalization within what our portfolios, but also at the country level, the mobilization of more domestic resources in partner countries. This again poses a lot of challenges, as you pointed out, David. Well, what SDC? How do we navigate now this very blurred and very difficult landscape? I'm going to give an example of the pandemic preparedness and response from the Swiss government. First of all, instead of supporting new ventures and new narratives and new funds, we tried to adapt the mandates of existing organizations to the current context and needs, and to promote complementarity. Because a lot of our partners sitting here in the room, they already had pandemic preparedness and response functions. But in our narrative, it was not understood as such, Because UNAIDS is about pandemic preparedness and response. The Global Fund is about, PPR is one, it covers some functions along the PPR pathway. The NDI, fine, our partners here in the room, they also fulfill key PPR function. So again, trying to leverage and to build on what partners were already contributing to in the PPR space, instead of opening, again, instead of of further fragmenting the financing landscapes. That's the first. Yes,
maybe we'll have properly opportunity to carry on the conversation in the panel discussion, but I'd like to give the floor now to Alenta Ghebreyesus from the Ethiopian mission. And I would like to have your take on what impact this funding crunch might have on a country like Ethiopia. What could you say about that? Thank you. And please.
Thank you very much. I'm very happy and pleased to be here, honored to be here. Thank you for organizing this meeting, which is very timely. So let me start by highlighting the vision of Ethiopia. Ethiopia envisions a healthy, prosperous, and productive society through the health strategy and several initiatives. And health has been recognized as a key fundamental issue for development. So with this, there are several approaches, including addressing social determinants of health, leveraging innovative financing mechanisms, and also aligning commitments of external assistance with domestic resource mobilization and national priorities. So these have been the priorities for Ethiopia lately. But the fact of the matter is there is a huge reliance on ODA as Ethiopia. The health expenditure is significantly dependent, with 1/3 to nearly half being dependent on ODA. So the recent funding crunch would have significant impacts, and you can imagine how that would impact on essential health programs, on maternal and child health care, in pandemic preparedness, communicable and non-communicable diseases, including HIV, malaria, TB, which we've made significant gains towards achieving the SDGs. And also training, this would also pose a threat into the Ethiopia's progress towards achieving the universal health coverage. So these are one of the issues. There will definitely be stalling progress in achieving the health system goals. There is a huge youthful population, so the impact would be more seen on the pediatric population, the youthful population, which are huge in terms of health as well as development. There's also a point on pressure for domestic resources. So the more challenged we are in this without sufficient external support, then there would be prioritization and also affecting several other domestic resources, including education and other sectors. So I'll stop here and.
Thank you very much indeed. I think I'd like to invite now David to join the panel, because we will have a panel discussion, after which you'll have a Q&A. You can ask questions here in the room, but also online. So we'd like to carry on the conversation, and starting with you, Alenta and Erica. Both countries are actually working together, and I would like to have maybe a conversation about that. How does Switzerland, how will Switzerland navigate with its approach of global health as far as Ethiopia is concerned, since there is a strong fiscal pressure now on the budgets? How do you see that? We heard Alenta saying basically that it will have an impact. It might have an impact on global health, but also on other programs, because there will be priorities to be fixed, and obviously it's a big impact. So how does Switzerland respond to this?
Well, so as I say, for us, the first measure is really to foster and to push for complementarity. That's at the global level. Maybe some of you know that the Swiss Agency for Development and Cooperation uses many instruments to support health. You have global thematic normative work supported through the Global Fund, WHO, and contribution to the big health organizations. But then you also have bilateral cooperation in health. You have many other instruments. You have, for example, secondments. You have a contribution to Enlarge EU. You have the contribution to Swiss-based NGOs and etc. All these instruments are supposed to provide leverage and to be complementary. So the fact that we do have many instruments, of course, it has high transaction costs, but at the same time, that's the added value we have. If you have bottlenecks at the country level, then you act and you take action at the global level, in WHO fora, when it comes to resolution and etc. So complementarity of instruments, action at the global, at different level, and at the country level, and leverage. That's the first point. Then, of course, at the country level now, because you asked about Ethiopia. So we do have health programs in 23 countries, 22 or 23 countries. And it's always, we also always take a systemic approach, which doesn't make for a sexy narrative. I mean, it's very difficult to come with a case for investment. We are taking a systemic approach to support. But at the same time, this is exactly what we need to avoid further fragmentation at the country level and the creation of vertical needs and responses. And again, I'm going back to the PPR response. So at the country level, now in Ethiopia, we work on One Health, for example. So it's again PPR. Rather than having standalone, for example, mental health or One Health responses or PPR responses, what we do is that we integrate those functions into ongoing health system strengthening efforts. You know, it's not sexy, it's difficult to explain what a health system is. In most of the country, it's not about strengthening, it's about transforming. But again, then if someone comes with an MPOX, what do you do with MPOX? Do you have MPOX program? And then I said, well, in the Great Lakes, we do have a systemic approach. We take a systemic approach. I mean, strengthening the primary health care services. It includes sexual and reproductive health services. So it includes MPOX. So you see, it's really about the narrative and the way you describe a health system.
Thank you. Yeah. Alenta, how do you respond? What do you expect actually from donor countries now that we have those fiscal problems? How do you navigate with that, and how do you prepare for budgetary problems?
So thank you very much for that very crucial element, and I want to pick up on the issue of complementarity and also avoiding fragmentation. And we're very happy for the continued collaboration and cooperation we have with Switzerland and other countries and partners and stakeholders. And Ethiopia, as most of you would know, has a plan for one budget, one plan, and one plan, one budget, and one report, which would align all these and also include has a contribution for efficiency and effectiveness. So we do that. We have an SDG pool fund, which is a sort of basket fund, which would also is used to put resources. We're also trying to do some innovative financing mechanisms, including the family planning compact, where governments would have to do matching fund for health system strengthening. That would also increase the government investment in health. We also are in discussion with the health fund establishment, which would cater for resilience, health system strengthening, equity, and of course, preparedness for pandemic. So these are some of the efforts being carried around. We also are heavily engaged with the Lusaka agenda, as most of you would know. Yes, there are key strategic shifts that governments would have to employ. So we would expect to go in this line, and also to focus on country priorities and needs, and to not duplicate efforts, while still making sure that this funding crunch would be done in a systematic way, in a systematic approach, so that countries would have the capability to build their own investments, and we will sustain the gains that have been made.
Thank you, Alenta. I'd like to give the floor to David Evans, because Erica was talking about the need to rationalize health in different countries, but you were also talking about certain countries, for example, not being able to invest in global health because we have to pay debt and whatever. How do you see this whole conversation about rationalization of health on a national level?
Thanks. Let me divide my answer into the global level and the country level. I mean, some of the countries, as I said, are going to be able, some of the low and lower middle income countries will be able to spend more on health. They're growing quite nicely, and they can do it if they wish to. The ones that can't, there's a question of, at the domestic level, you could say, yes, they need to get more efficient, they need to develop the health systems. But the problem is when you're spending $10 or $15 per person per year, there's a minimum level you need to be efficient. You need a certain number of health workers, you need a certain number of facilities. If you don't have them, Erica said it's more like a transformation in those countries. And for us as rich countries to say you've got to get more efficient and they're spending $10, it's a little bit, I can't think of a polite word, but it's some countries can be more efficient. So I think in some countries it's really helping them get the systems working and get the development, but I think the macroeconomic environment can change as well. So some of these efforts to reduce the debt burden in these countries, it's a political problem because some of the main lenders are saying, look, they got themselves into their own problem. They took out too much debt. The leaders that were not responsible took out too much debt. And so we're not going to forgive the debt, or we're not going to delay or reschedule the debt. But other people are saying, look, hang on a bit, everything's going to collapse if you don't. So I think there can be more at the international level to try and deal with that. If I talk about the global health architecture, yes, I mean, everyone says it, it's fragmented, it's not fit for purpose. As you can tell from my beard, I'm not young anymore. I've been around this system where everyone's been talking about rationalizing the global health architecture for 30, 40 years. It hasn't happened. It's got more fragmented. I don't have high hopes that that's going to happen in my lifetime, but maybe in your lifetime it will. But I think it needs to happen. And Erica talked about the way Switzerland's trying to come to terms with that by focusing on integrating within existing organizations rather than new ones. But, you know, every day there's a new request for a global public good support, et cetera. And it doesn't help the countries that need it most, in my opinion. But as I said, I'm not providing definitive answers.
Thank you very much, David. Now I'd like to open the floor to the Q&A here in the room, but also online. Please ask your question and maybe tell us whom you're addressing your question to. So please, in the room, starting with the room. Over there.
Thank you very much. My name is Mariska Meurs. I'm from Wemos, an NGO in the Netherlands. Thank you very much for your inputs and your presentations. One of the things that I did not hear mentioned is the issue of taxation. And one of the things underlying also the decreasing budgets in high-income countries is I think an unwillingness to continuously to tax the what we call the high wealth individuals and companies. And it's also an issue for many low-income countries who are still losing lots of funds through illicit financial flows, tax avoidance, tax evasion. And I did not see it among the opportunities, David, that you listed for increasing spending room for countries. So I was curious to hear your views on that. Often in global health spheres, when we raise this, we hear, well, this is not up to health organizations, but I think it's up to all of us who want more spending on development goals, on public goals whatsoever. So really interested to hear your view on that. And the question also to Erica, you mentioned the Swiss Development Corporation invest in systemic approach, which is great. In the Netherlands, we see, as I think many other donors, that it's difficult to explain to the public. So do you have maybe tips of how you sell this approach and make it understandable to the broader public? Thank you
very much. David, maybe to start with?
Sure. I mean, you're totally right that is something that has been discussed a lot, and countries have signed on internationally to this idea of taxing fairly the global multinationals and the high-risk companies that transfer price across the different countries, and I think it's really important. I didn't put that as one of my opportunities in the sense that I listed things that are happening. I don't see much happening on the taxation side, similar to the rationalization of the global health architecture. But I think that a lot more could be raised. It's also for the low-income countries themselves that often grant tax exemptions for companies that they wish to have there for employment reasons, but they could raise a lot more. So yes, it is an oversight. It is important. Sorry, and one other thing that I forgot to say last time is that a number of the high-income countries are growing nicely. Some of them are in the contraction group, but some of the high-income countries are in the expansion group. There's no reason why they couldn't give more to development assistance. It's a political issue as well for those countries, but it's not as though every country is financially constrained and so can't give more for development assistance. They could if they wished in some of the countries, certainly.
Thank you, David. Erica, how do you tackle this communication kind of issue when you have a systemic approach and you have to sell this to a general public?
Let's come back again to the MPOX. It's easy to explain that it's a basic function at primary healthcare level can address MPOX, including vaccination. So you use the disease, but then you turn it and in your narrative, you make sure, it's that you explain that there is a need to take actions at different levels, including outside at community levels, So, but still, still, the disease is what people understand, So you have to use the disease, and then you go back to, and you explain how it is embedded, the response is embedded within the health system. You don't start with health system strengthening, of course, because nobody will understand. And then we often use and that's internal and external. We also use, the cost of inaction of not taking a systemic approach, Is that you further fragment, but you also invest a lot of resources in tackling just one disease, where you could, the PCR machines for COVID-19, that's a great example of that. We already had PCR machines, for malaria, we don't need to have PCR machines for COVID-19. We could adapt, use, and etc. So that's another example using the case for investment built around the cost of inaction, efficiency, etc., including from a donor point of view, but also domestic investments.
Thank you, Erica. I have a question online from Olena Wagner. The question is for you three. How do you see the systemic approach to an issue of drug pricing, cost financing, for non-communicable, complex, and rare diseases in countries of modest income levels and beyond? Who wants to answer this question?
Very complex one. Can you repeat?
Yes, how do you see the systemic approach to an issue of drug pricing, cost financing for non-communicable, complex, and rare diseases in countries of modest income level?
Yes, that's a great question, because it allows, again, it's very difficult to explain. I have my colleague here in the room who is responsible for access to technologies and medicines. So it's again, it's a systemic approach. We start with the research and development of new drugs, new technologies, which are of interest for low and middle income countries. And then we start, and we cover, the entire pathway, access pathway, from research and development, to at the country level, or at the primary healthcare level most of the time, because we do have a focus on primary healthcare facilities, and then this is where the drug is given and is offered to the population. So again, covering the entire pathway, only focusing and investing in R&D doesn't make any sense. Only investing the Global Fund to bring, technologies and medicines at the country level where for diseases and medicines where you don't have research and you don't have new products doesn't make any sense. So you have to really invest at every single milestone, which again allows an orchestrated systemic approach to access.
Thank you. You please.
Thanks very much. It's actually not an easy question to answer, to address, but it takes us back to the current negotiations for the pandemic prevention, preparedness, and response, and also the ones by the amended international health regulations. So I think it has to do a lot with having conducive environment for sustainable local manufacturing, geographically distributed, diversified, sustainable manufacturing, which would entail the whole chain, starting from research and development, supply chain and logistics, the regulatory system strengthening, issues with technology transfer and know-how. So all that has to be addressed in a systematic approach, and specifically having this capacity built in countries at country level, at regional level would be very key. Thank you.
Thank you very much. Unfortunately, I'm sorry, we don't have much time for further questions. I'm just going to read very quickly a remark by Labila Sumaya Musoki from Uganda, saying, I suggest tackling the rising debt crisis that Uganda and other low-income countries continue to grapple could save dollars that would be invested in health. That is possible if IMF and World Bank consider debt cancellation rather than restructuring. That's how I wanted to conclude that with. All right, we're going to move to another conversation with Joyce Nanga from, she's a policy advisor at WAKI in Kenya. And we're going to talk with her online. She's right here. And thank you very much, Joyce, for being here. And you're representing in a way the civil society organizations, and I would like to start with. I'd like to have your take on what funding crunch means for the civil society concretely in the field. You're in contact with people, and you see that from very close. So I would like to have your first take on the impact of funding crunch. Please, the floor is yours.
Thank you very much for that question. And I will reflect on communities and civil society and what this means for us. As civil society and communities, we are very worried and very much concerned about the global funding crunch, its trends, implications, due to various reasons. Allow me to discuss 5 of these. 1, reduced funding for health will lead to deaths, increased deaths. Unfortunately, we can expect to see increased new HIV infections, particularly among adolescent girls and young women, increased maternal mortality, teenage pregnancies, increased TB cases, and other preventable diseases. The lack of resources limits access to life-saving treatments and interventions, disproportionately affecting vulnerable populations and potentially undoing years of progress in public health across lower and middle income countries. 2, we are already at a deficit. Health is underfunded. Many health systems, especially in low and middle income countries, would not be able to respond to a crisis. Our health systems are still recovering from COVID-19. And we saw that in a pandemic situation, it's the most vulnerable people who suffer the most. 3, increased unacceptable out-of-pocket expenditure. The largest portion of health expenditure comes from out-of-pocket costs. This reliance on personal payments for healthcare means that more people are at risk of being driven into poverty due to catastrophic medical expenses. Without adequate financial protection and public healthcare funding, individuals and families will face severe financial hardships, further deepening poverty levels and limiting access to treatments and services. On 4, shrinking civic space and right space in situations like we have seen of human rights violations and shrinking civic space coupled with inadequate funding for health, the result is a disaster. And people will continue to lose their lives and also to suffer. On my last point, the current global health landscape is already faced with a poly crisis. We have seen pandemics. We are talking about mpox. We have seen COVID-19. We are also faced with increasing food shortage, climate change, war and conflict. It means now more than ever, we need to think about this intersectionality. And a funding crunch will definitely affect our ability to respond to this, which will further push communities into a crisis. We need to make health a priority. We need to make health a political agenda. I believe that there is enough money in the world to fund health and to replenish the global health institutions. That's a global fund, the Global Financing Facility, Gavi, World Bank, etc. As civil societies and communities, we refuse to accept that there's not enough money to fund health. Thank you.
Thank you very much, Joyce. Maybe could you give us maybe an example of, if you already have seen it, an example of very concrete example of the impact of funding crunch in the community you're working in? Could you give a very, very concrete example of, and how you try to navigate with that?
Yes, I would perhaps speak about, let me give an example of the HIV response and make a comment on declining funding on health R&D. Health, that's health research and development, and especially on the HIV funding, there has been a decline over the years. And this means that we are unable to do effective research to get effective tools for prevention and treatment for the populations that need this. It means that we are not able to have research that can give us indigenous solutions for increasing HIV cases, especially among adolescent girls and young women. So the trends for HIV funding has been declining over the years, I think the last 7 years, and it is worrying that we may not be able to carry out research to get own local tools for prevention. I would comment on that among many others where there's a decline. Also to note that when there's a funding decline, it's the communities and civil society that lose out the most. The money does not reach the communities where communities need the resources, because communities are resilient, the solutions are within the community. But where there's a funding crunch, it means it's even more felt at the community level because the resources do not reach the last mile.
Yeah, how do you, because you were talking about the different challenges that Kenya or other countries are facing. You were talking about polycrisis, about the food shortage, about climate change and things like that. To what extent does global health, what's the impact on all those polycrises on global health funding? Obviously, how do the government kind of outweigh what's necessary for global health, what's necessary for climate change and for food shortages?
Yes, unfortunately, we have not seen a very deliberate separation of, resources, that this is for, addressing climate change, this is for food shortages, and this is for what? I think our government have relied heavily on external funding. We saw that during the COVID-19 where we relied heavily on external funding to respond to COVID. But during COVID, the government also came up with policies and guidance on how to respond. And so we had policies around accessing essential health services, which we were very much engaged in that policy formulation to say in a time of crisis, essential services should not be affected. So I would say, especially in lessons that we learned during COVID-19, is that the government were able to come up with a policy formulation such that essential services were not affected. But that did not come until communities were involved and communities were engaged. And when communities came, advocacy from communities, that's when we started seeing shifts, including acceptance of COVID-19 vaccines within the community, as there had been lots of vaccine hesitancy. But we saw how communities can be resilient because with the community response, we were able to take care of this pandemic crisis. So I would say communities really heavily involved in the policy formulation to ensure and to secure essential health services delivery during pandemics, during times of crisis. I think we have made progress, and COVID laid a good foundation. And therefore, we have talked about pandemic prevention, preparedness, and response. And I think countries are getting ready in the eventuality that we get another pandemic. We already have mpox. The response could be better, but we are seeing our government rising to the occasion.
Thank you very much, Joyce. Stay with us. We're going to now have a second panel discussions with all our guests here, our panelists. And rebounding on what we were saying, I would like to ask a question maybe to Erica. We heard Joyce saying that, you know, there's enough money in the world, there should be more help and things like that. You're, if I understand you well, you're basically saying that we should have some kind of paradigm shift in the sense that we shouldn't see development assistance the way we have seen it over the last decades. What's your general take? How do you explain this?
First of all, can I say a few words
Please.
on the CSOs and involving communities in the response and in the design of health interventions at the global and at country level. First of all, in this, I was mentioning the systemic approach and the instruments of the Swiss development cooperation in health. And at the global level, for example, these are just two examples. At the Global Fund, every 2 years we are alternate at the board of the Global Fund, and we push for more finances and more budget for the community response. Now it is clear that with the COVID-19 response, everything has been, focusing on infrastructure at the facility level, primary, secondary, tertiary. So it was all the more, it was very important still to insist that that we do have, we have to think about this in not only at the Global Fund, but also at WHO level and in other with other international organizations we are supporting. Now, at the country level, a big component of this systemic approach, of course, is what happens outside of the health facility. This is very important. So it's not just about primary health care, includes prevention at the community and promotion at the community level. So it's still part of, and that's the most difficult part to explain, that what is outside of the facility, it's still about health, And another way of doing this, in my opinion, in a very smart way, is when you combine two themes, two root causes of ill health. You take malnutrition in all its forms and consequences of the climate, biodiversity, consequences of climate change. So think about root causes and the kind of cost-efficient and cost-effective response you can draw. You can introduce at the community level. So with the same group, with the same community, you can do prevention for nutrition, for climate change, for biodiversity. That's another way of doing it. When you have less and less resources, you still don't stick only to health. Health is a consequence. The root causes is malnutrition, biodiversity, etc. So you see, the narrative is very broad.
What's your general feeling about that, Joyce? Maybe if you want to respond.
Yes, I would like to agree on the social determinants of health.
Exactly.
And that, yes, and that we need to address the systemic issues for health as well, and that health is beyond the health facility. And everything happens within the community. By the time the cases are coming to the facility or to the hospital, the community health system has failed, because there should have been preventive and promotive care at level 1. That's the community level. And I think most of the LMICs now have a deliberate strategy on community health and how health is structured, and that the basic unit is the primary level, which is the prevention and promotion. So I like very much the emphasis around primary health care, and that it should start there. And that's helpful also to decongest the other levels of health, as if we don't prevent well and we don't promote health, then we end up with many complications that come now to the health system, and find a health system that is already strained. And that's where we go wrong. So I do really appreciate the emphasis around primary health care as where it all should be happening for health, and addressing, of course, the social determinants of health.
Thank you, Joyce. Alenta, would you voice something about what Joyce was just saying? Or
I would also agree on the emphasis for health system strengthening with a primary health center. Primary health care approach at the center. So Ethiopia has been having significant experience in the primary health care approach. We have a structured system where we have community workers reaching into every household. And we've reaped the benefits. We've seen the benefits, and it's very much in alignment with the agenda and the effectiveness as well as cost effectiveness of interventions.
Thank you. David?
Yeah, maybe I can just comment on Joyce's point that there is enough money in the world. You refuse to accept that there's not. And I strongly agree there's enough money in the world. It's persuading the people that hold it to redistribute it. That's the question. And those of you that know me know that I didn't discover how to have children until very late in life. And I've got a 15-year-old and a 9-year-old. And sometimes I find myself struggling to try and give them an optimistic view that you can change the world. It's possible. And I sort of try and reflect of how do you get this redistribution necessary to continue the good work that's been done in health over the last 20, 30 years. And I draw on my experience a little bit with the universal health coverage work, when there was a big debate about whether that was too ambitious and whether it was too much. I ended up speaking to a number of parliaments in developed countries about the need to allocate funds and to universal health coverage and why this was important. And I didn't do it just because, I didn't call them up and say, I'm David Evans, or come on, I'm going to talk to your parliamentarians. How I got in was that civil society said to their parliamentarians, you've got to hear about this. You've got to understand why it's important to have on your agenda. And I think that's where I have the optimism that, optimism in inverted commas, that comments that maybe my kids can contribute to something is the pushing of the parliamentarians that the rich people and the rich companies have their ears, but the pushing from civil society and the people eventually gets you in the direction that you would like to go, I think. And it's got to continue. It's got to continue. It can't stop, because otherwise the rich and the powerful will block efforts to redistribute the income that you know is necessary, and it's there. So I don't know whether that's too optimistic. Yeah, tell me and I'll go home and talk to my kids.
Thank you, David. We're going to now open the floor to questions to the room, but also online. Please ask your question. I'm just going to ask a first question online for Dr. Evans. Does the funding cuts by bilateral donors mean there will be a greater role for private foundations to become more prominent donors in the future?
That's a tricky one.
Erica just said that's a tricky one, so maybe I should just finish there. I mean, already the private foundations in health are very important in terms of the proportion of the development assistance that comes from different sources. So any further decline in bilateral official development assistance will mean that their role is greater. I haven't actually looked at the numbers recently about what's happening to their funding over the last few years and whether that's also declining, because that will determine a little bit. But I think maybe along the lines of the NGOs and things, I think there are very high net worth individuals and companies in many countries that haven't been tapped for this sort of thing, and that it's been a struggle to try and get some of them to contribute to this. But I think that might be a role in the future as well, for trying to get some of the high net worth individuals and companies to contribute more than they've done in the past, maybe from countries that haven't been doing this in the past.
Thank you, David. Now I open the floor to, please ask a brief question so that we can have as many questions as possible and say to whom you address your question. Thank you.
I'm Robert Bos. I was with WHO for 32 years, but since 2013, I'm an independent consultant in public health, environment, and water and sanitation. And the discussion between Joyce and Erica was sort of music to my ears. It takes us back to the 70s and 80s.
Yes.
Primary healthcare and intersectoral action for health were at the forefront of the activities of WHO. And so this is very true that the environmental and social and economic determinants of health are the ones we want to tackle at the community level. My question goes back to what David said at the very beginning, because you did the analysis, David, and you made this distinction between the various low and lower middle income countries in terms of their capacity to sort of raise their own funds and do this. And the question then is, if that is what you show us for the health sector, but are there countries where, for instance, the health sector is on the decline in terms of availability of funding, but other sectors are up? Are there opportunities there to see whether we can build in health components into these other sectors, so that, because we all know about health co-benefits of, for instance, climate change action or in agriculture or whatever. So can we use that as a mechanism to counteract, in a way, though, in those countries, the budget crunch they're facing on the specific health sector related funding?
Okay, who wants to answer? Erica?
No, please do.
David?
It's also a tricky one.
The short answer is yes, but I mean, obviously the intersectoral action and the social determinants are very important as well. Many sectoral budgets do already. I mean, early childhood development is one that's often cross-sectoral in different countries. It's not just health that's pushing it, it's education as well. That being said, the budget process can be quite complicated, and the sectoral ministries or departments are very reluctant to share resources. So some countries, I think New Zealand was one of the countries that introduced they keep part of the budget for priorities that are cross-sectoral and ask the ministries to go together to put in an application for the extra budget that may meet the government priorities. That is a way that worked for 4 or 5 years, but the change of government recently means that, as far as I understand it, that has stopped. So it's politically complicated to do. Just a quick point on whether health is going up and down. I mean, a trite point is that, yes, obviously in many countries, the defense budget's gone up dramatically recently, and the insecurity in the world has meant a lot of countries that are not affected by war are now covering themselves as well. But we've just looked recently at the education sector in low and middle income countries, and they've actually done worse than health over the last few years, where the share of the government budget to education has actually fallen in a number of low and middle income countries, and on average in low and middle income countries, whereas the share going to health has stayed pretty much the same or increased a little bit. So in a place like the bank, for example, when the health people get up and sort of start saying we need a higher share for health, the education people will say, well, hang on a bit, we're getting less at the moment, and it's not just health. Maybe this cross-sectoral part is one of the ways of dealing with it, obviously.
Thank you, David. Erica, you wanted to add something?
Yes, just an example. I mean, I think addressing non-communicable diseases is a good starting point, to start this conversation with other sectors, because as you know, risk factors, they lay outside of the health sector, so you have to bring on board, there is a shared responsibility in addressing them. So I give you an example from Moldova. In most of the country, I was talking about systemic approach. One big component, a key component, is about reshaping the entire health financing landscape. So our support in how, for example, to reshape the insurance, so it covers basic package and etc. And in that sense, I mean, for example, in Moldova, we tried to have on board the Ministry of Finances, the Ministry of Transport because of alcohol, So, and we set up a kind of temporary, a small budget pot, which would have been, it's like a pooled, pot pooled with budget pooled from different departments, and just to show that it could help. But I mean but it's not about additional resources. First of all, you have to rationalize the health insurance scheme at the country level, because it already, showed that a lot of money was available. It's just the way it was allocated, like the number of beds, not occupied beds, the number of beds at the hospital level. So first of all, rationalization, you free resources. If it's not enough, you try to engage in a conversation with the other departments. So with non-communicable diseases, it's easier because then, it's about alcohol, cigarettes, and sugary drinks, and trans fatty food items, and etc.
Alenta, you wanted to add something as well.
Yes, very briefly, I do agree that there's a huge opportunity to tap into other sectors. We have an experience with the Boreda transformation. I can give you an example of decreasing in neonatal and maternal mortality. It requires roads to be built, infrastructure, lighting to be there, the facilities to be equipped, human resources to be trained, and also this would require all sectors to come into action, into play, coordinate, and this also, of course, requires political will, political commitment, and a great deal of coordination. So there's an opportunity, but we have to be very strategic and really try to mainstream the health for all agenda.
Thank you.
And health in all policy.
Right. Another question, please.
Thank you very much. I'm Muhammad Yassin from Sudan. Just my question goes on, when we talk about global system, that means group of elements interconnected. And when I see the ongoing crisis in Sudan and the total collapse of this health system, totally collapsing, that means, and in addition to that, the millions of people crossing to the neighboring countries, that means they will rely on the already stressed health system of the neighboring countries. In addition to that, there are suggestions also of using the local manufacturing of drugs and production of that. But this is very risky because of the inability of the local systems also. And this is also open windows for low quality medicines and maybe sometimes fake medicines and so on. This increase the of the situation. So in to this potential crisis with the increase and continuity of the war, what could be done in order to prevent a potential pandemic, maybe potential pandemic which can be caused by the protraction of this crisis? Thank you.
Thank you. Who wants to answer about the very difficult situation in Sudan and the strained health system? No.
I mean, maybe someone in the audience is better placed than I am to do that, because I certainly when the health system breaks down, the risk of pandemics is much higher. I'm not a pandemic response person, so I have no idea what you can do at low cost in that sort of situation. Does anyone else have? So sorry, I can't give you an answer on that one.
I'll ask a question online by Guillaume Lausier. Could the lack of transparency and efficiency in the allocation and use of health funding be a significant barrier preventing donors or government from committing more resources to critical health initiatives? Erica?
Yes, of course, it goes with the fragmentation. So, of course, accountability, the less you have, the more the level of accountability which is required is an issue. I mean, so it is clear we are interested in what organizations do, the products, but we are also interested in how they do it. But institutional governance, cost efficiency, cost effectiveness issues, these are, of course, are part of our risk matrix on every single assessment we do before investing in not only interventions at the country level, but also at the global level. So yes, it's an issue, and it's one of the criteria, which we consider before supporting, being it at the country, but also at the global level.
I have a question by Paul Marsden, Technical Officer at WHO. Major funding component of health equal the workforce. Why are we unable to secure more opportunities for cross-sectoral engagement and investment in this area, given the employment of health workers can have a positive impact on health, economic, and social outcomes?
It's part of a systemic approach, but you cannot only address it. We support a WHO ILO initiative on, but you can, and at the same time, there is a colleague here very much involved in medical education for nurses and medical doctors, and in most of the countries where we work. So there is, you can support the medical education reform at the country level. Of course, this is what we do in Bosnia, in Ukraine, in Moldova, Central Asia. But at the same time, you have to invest in market dynamics at the regional and global level. That's where it's very important not only to educate people, but also to give job. To be sure that there is a proper assessment, that you know how much nurses you need, and for that you have to take a regional approach, because as you know, most of you know, it's very difficult, even for a country like Switzerland, to know how many health workers we need. It's a sensitive political issue, so it's very difficult. You have to address both. At the same time, education, but at the same time, to be sure that market dynamics and that are there is governance in the way people are, recruited at the regional, country, and at the global level. That's again 2 instruments.
Thank you, Erica. I personally have, I'll get back to you. I have a question for you, Sri. We've been talking a lot about the fragmented scene of global health financing, and here for our audience online and here, Geneva is a place where this fragmentation is physical, because we have the Global Fund to fight AIDS, tuberculosis, and malaria. We have the World Health Organization. We have Gavi. We have UNAIDS and things like that. So this fragmentation is physical. And I was wondering, because this conversation that is going on in the health domain, there are people who say we should stop with those vertical funds and we should move to something more horizontal. And I was wondering if you could voice your opinion, or maybe Alenta, if you have a point of view on that.
I believe it's very important to focus on health system strengthening, and the speaker, there was a question also regarding ongoing conflicts and humanitarian settings and how best to address them. So the key would be to focus on health system strengthening, and of course, make sure that support or any such collaborations are aligned to government priorities and needs, and that we also bridge the gap between the humanitarian development nexus, the health humanitarian development nexus. So one is that. The other point I just also would like to address is the key stakeholders would have a very key role to play. We've heard from our colleague representing CSOs. They have a really great role for advocacy at different levels, at political level, at different levels. Several institutions, including Global Fund, Gavi, several other institutions, which also it would be important to harmonize and prioritize high impact interventions and of course align efforts. And there are also discussions in this way regarding coordinating financing mechanism in the pandemic agreement ongoing negotiations. And other stakeholders, including philanthropy, would also have a stake in really collaborating with governments to maximize impact where we have government priorities. This would be my response.
Do you have a take on this discussion about vertical funds, David?
It's probably better that Erica responds. I'm an ex. I'm a has-been. My opinion is sort of irrelevant these days. That being said, I don't work for anyone anymore, so that I can probably express them. But I mean, if you could start again, the system would look very differently to what it is now. But that's an easy thing to say, because getting the key stakeholders, which are the countries, and every country has one vote in WHO, in the World Bank. Not every country has one vote. It depends upon how much you pay in. Each of the organizations, the governance structure is very different. But if I can use my experience in WHO as an example, as you know, WHO has regional offices, and everyone who comes in as a new DG or new advisor to the DG and WHO says the regional structures don't work, get rid of them, we'll have to reform. It's not possible, because the regional offices, the countries in the region, vote for the regional director. You've got to persuade those countries to abolish their regional office. It hasn't happened. I can't see that happening, because there's so many interests in keeping the regional office, and some people might get jobs, retirement jobs in the regional office, or they might get voted to be the regional director. You've got to get those few countries to vote to abolish them, to get a more WHO that works in that sense. So when you expand that to ILO and the Global Fund and Gavi and all of these things with the different organizational structures and different interest groups, and some country has more influence here, some country has more influence there. I don't see it happening. So that, you know, I might dream of a better world in that sense of me establishing a new global infrastructure, but I don't think the countries are ready for it. But that's why I said Eric is better to respond to this than me.
Just 3 words. First of all, donors are part of the problem, so they have to be educated. They have to be proud of their health system strengthening narrative, and less is more. That's it.
Thank you very much indeed. I'm sorry we have to wrap it up. So I'll give you a few takeaways from this very interesting conversation. I think all the panelists were just wonderful, and it was very instructive. As far we could hear some kind of pessimism as far as the global health funding crunch is concerned, but I would come up with a few silver linings if you want, covering a little bit global health issues here. 2 years ago, I think WHO has increased its assessed contributions from 16% to 50% by 2030, so basically 20% per year. And that has been a struggle for many, many years. I remember Angela Merkel in 2015 wanted to increase those assessed contributions, never worked, and eventually WHO did it. So that's a positive move, I would say. And what I found also positive in a way is the fact that also under Merkel's guidance was to put on the top of the agenda global health issues at the G7 and G20. The problem is that they didn't follow through. But because we all know that global health issues should not be tackled only by health ministers, but by the whole government. And because it implies so many other issues related, we heard that, we heard Joyce with, education and things like that, obviously. And I don't want to end up with a pessimist note, but I was told yesterday that at the Summit of the Future, which takes place on Sunday and Monday in New York, there was a proposal for emergency platform, non-military emergency platform. Unfortunately, this proposal has disappeared from the draft, and that's a bit sad, and it tells a lot about, it has volumes about, the priorities we tend to fix in terms of global health. That's about it. I'm going to hand the floor to Vin Kim to wrap it up, and thank you very much indeed.
Thank you.
So I have 1 minute to wrap up a very rich and fascinating discussion. I think what I would like to say is that we've certainly seen very convincingly that there are powerful headwinds, that we're sailing into powerful headwinds in terms of a financing crunch, and that there's a tension between calls for efficiency, which, as David pointed out, does not make much sense when you're below a certain threshold, and redistribution. And so there's a broader politics of this, which Joyce brought up also quite powerfully, which reminded me of the success of the HIV movement in the 90s around access to treatment. So I think that's an optimistic note, but it points to the importance of alliances and of politics within a broader context of a changing geopolitics and fragmentation. My provocative and sort of, I'm a physician, so we have a dark sense of humor. You thought economics was a dismal science, but this is even more dismal in a way. What seems to really increase spending is a good epidemic or a good war. And unfortunately, we have lots of wars, and we have probably more epidemics on the horizon. So one doesn't have to be that pessimistic when it comes to funding. That's sort of my dark humor. So on that light note, I wanted to thank you all for coming here on behalf of the Global Health Center and the Center for Finance and Development. We're going to have another cheery, upbeat event on the 9th. Is it? Yeah, on the 9th of October, on something that I find is dear to my heart and that we've been working on here on antimicrobial resistance, which fits into our general topic of the next pandemic. So thank you all for coming and for tuning in. And do we have enough food for everyone? Yes, upstairs. Okay, so I can tell you there's some food and drink upstairs. So thank you.
Thank you.